Now we move to the last talk, and the title will be Screening Strategies for Nosocomial MDR Pathogens. The speaker is Dr. Tibor Pal. He's a professor of microbiology, consultant clinical microbiologist, Department of Medical Microbiology and Immunology, FMHS, United Arab Emirates University.
Thank the organizers for inviting me, and apologize, quite a few slides of mine need to be skipped because of the time constraints. So the title is Screening Strategies. However, I'm not going to give you any guidelines and any clear strategies because I believe there are no such thing which would be generally applicable for all multi-drug resistant organisms, and in particular which would be applicable anywhere in the world. What I would like to do rather is to highlight those factors, those points which we need to consider when designing our own strategies. So as we all know, our hospitals are full with bugs. But the problem is that we also bring in our own bacteria when entering the hospital, and one of the major aims of these screening strategies is to filter out those patients. The big question is, however, should we screen or not? And if the answer is yes, whom should we screen when, for which pathogens, how, and probably one of the most pressing questions, what to do with the results? Actually, even the first question is not that easy to answer because there are a number of people arguing strongly and vehemently with very good arguments that maybe screening is not necessary. We should just follow general good infection control practices, and that is good enough and certainly more cost effective. I'm certainly not here to take a position on this ongoing very fierce debate, but certainly the fact is that surveillance certainly reveals more carriers and more people who are actually carrying these MDRO pathogens than if we would just completely rely on clinical microbiology. Well, by now this is a classic. This article published in Journal of Clinical Microbiology to screen or not to screen, and that is the question of Shakespearean proportion, and the answer is certainly not clear. And there are many examples. Of course, that was about MRSA, and this is where we have the most experience with MRSA screening or not to screen. There are hospitals or there are countries vehemently arguing that yes, indeed, we need to screen, and it's good, while others say that, okay, but we don't. And we don't have worse results than you do. I believe that a lot depends on where these hospitals are located and what are the local epidemiological situations of the particular MDRO or MRSA. Just to give you a few examples. There was an initiative in the Veterans Administration hospitals in the US a few years ago, pretty much introducing an absolute general screening. Very soon, an article appeared that actually the excellent results they seen after introducing this general screening plus a strong infection control bundle associated with it, actually the good results were not really due to the screening introduced. Or a few years ago, legislation was put forward in Illinois and in Maryland, arguing for the general screening for VRE and MRSA. Soon enough, a publication appeared from experts saying that, well, at present, insufficient evidence justifies a mandatory application of this strategy to all hospitalized patients. So even the answer is not that easy whether we screen or not, but if we decide, yes, we do screen, then the question who we screen. And actually, the two extreme is that we screen everybody or we screen a highly selected population. Well, how do we define the population? One possibility is that we look where these people are coming from, abroad or hospitalized, or they went through previous antibiotic treatment, or where do they go? Do they target certain departments within the hospital? Do they face transplantation? Or so we may define this population according to where do they go. The most difficult question to answer is that if we try to define the population to be screened, where are they coming from? So how do we limit our screening strategies? If you look at the possible populations, the large blue circle represents the total population, and within that we can identify subgroups. Let's say those who had been hospitalized before or who had received antibiotic treatment, or a very important group who had possible foreign exposure. They traveled recently or they had been hospitalized in a foreign country before. Another important question is that, do we have any idea that how many positives we anticipate in a given population? Because if we need to screen hundreds of thousands or tens of thousands to find one positive, well, probably this is not an effort worthwhile. Or if half of the population we anticipate to positive, what's the point of screening? So we have to find a balance. But to find a balance, we need to have data that what do we anticipate in the population. We have to also consider that countries are different. Just think about the GCC countries, the countries of this region. I mean, we have a huge expat population, most likely having a much more extensive foreign exposure than, let's say, populations in the Scandinavian countries, right? We all have to this taken into consideration. We also have to know what is the rate of local transmission of the particular pathogen. Let me just give you a few examples. Very recently, we completed a study on CRE, Carbapenem-resistant Enterobacteriaceae, in the GCC countries. We investigated 200 cases from the four countries, Kuwait, Saudi, Oman, and the UAE. So based on these cases, what you could see here is that not more than 20–30% of the people with CRE infections had a positive travel history, irrespective of the type of carbapenemase carried. Hospitalization, as expected, prior hospitalization was nearly 70%, 70 or 80%, obviously in this patient population. Again, if you try to limit screening strategy based on previous hospitalization, basically you have to screen 80% to catch a number of the people. The important question is where this previous hospitalization took place. And we had identified 14 patients who had been hospitalized 1 year prior to recent admission in a foreign country, the overwhelming majority in India. What we found that among those, 80% were infected with an NDM producing isolate. We said, okay, bingo. So we have to screen those who had been hospitalized abroad, particularly in the Indian subcontinent. Well, that's not true, because even if these people represented not more than 20–30% of all NDM carriers, so that is not helping too much if we restrict our screening, considering CRE, only for foreign hospitalization. So then we actually tested that what was the rate of general foreign exposure, either travel abroad or foreign hospitalization, that we found that even in NDM carrying CRE, approximately 50–55% of those people had no foreign exposure whatsoever, and with other CRE strains carrying OXA or VIM, the figures were even higher. So it seems that locally in the GCC countries, foreign exposure, the presence of foreign exposure, is not a good filtering category if we want to screen for carbapenem-resistant strains. A very important question is how strong the carriership in the community. Simply speaking, we have no clue. We have no data in the peninsula how often people are carrying these pathogens. We just don't know. So regarding multidrug-resistant gram-negatives, the ECDC, the European Center of Disease Control, suggests a screening of those who had a foreign exposure, but warns, I think rightly, not to single out target countries, not to say that, okay, I screen if you come from there, but I don't screen you if you come from there. That would be a very, very dangerous approach to take. Screening can be proactive and can be reactive. Reactive screening is that if there is an outbreak and the hospital may decide that, okay, I have to do something and introduce screening for a targeted pathogen. That is usually easy. Administration is absolutely willing to give money for that because they want to control the acute situation without it getting out to the press. The real question is that what do we do as proactive screening in endemic situation? And that is usually the difficult question because you have to spend money on screening even without an outbreak took place, actually to prevent outbreak. Currently, the ECDC, the ICMID, the European Society, suggests that in outbreak situations, screening for multidrug-resistant gram-negatives is justified. However, they don't recommend screening in endemic situation. I have to admit that even not all European countries stick to this progress, and particularly in France, they have a very active screening program for this group of pathogens. These are the bacteria. You can see it in Dr. Zonovan's slide as well, the escape pathogens. And I already mentioned that there is no such thing as general screening. We vary from pathogen to pathogen. So I think my time is getting short, so I better skip the method. Let me just highlight this. When you choose a screening technique, you should be aware that that technique should deliver the same result 24/7. Even if the patient is coming in the middle of the night. And that applies because we have to decide that what do we do with the results? It's fine you have screening results, but what do you do with the patient? Do you have the capacity to quarantine the patient or to isolate the patient, to cohort the patient? Do you consider decontamination or decolonization? These are all to be answered in the light of expenses. There was a very recent, or actually not so recent, mathematical model study which compared different screening strategies for MRSA. And what they came up with, saying that everything depends on how much money you are going to spend. If you are not going to spend too much, here on the first column, do nothing. That's the most cost-effective thing. If you have some money, no screening in preemptive isolation of high risk or high-risk screening plus isolation would be the best. But if you have a lot of money, do PCR screening for MRSA, that's the best. Again, depending on everything what is available to you.
2 minutes.
So, yeah, I will finish. So basically, what is the conclusion of this very rushed talk? Set screening strategies based on scientific evidences. However, fine-tune them to your local needs. That's easy to say, but to do that, you need to know the incidence, the prevalence, the dominant clone types, the rate of carriership in various potentially targeted populations, the rate of carriership in the community, etc., etc., etc. So the take-home message is that we have to do our homework to analyze and to assess what are the local situations with multi-drug-resistant organisms in our region and set our strategies accordingly. As Dr. Zonovan pointed out, unfortunately, in these countries, these data, antibiotic surveillance data, simply do not match the level of medicine practiced, the level of clinical medicine practiced. So I think, and I firmly believe, that in order to set our own effective screening strategies against multi-drug-resistant pathogens, we have to just do our homework, that the data should not be scattered, they should be available not only for certain good hospitals, but nationally collected, should be validated and high quality. Thank you very much.
Thank you very much, Dr. Pal.